Hello, thank you so much for having me here to speak to you about weight management. And of course, I'm going to be talking about some specific concerns that we would think about in patients who have acromegaly. I have no disclosures. And here you can get a sense of our objectives today. We're going to talk about some basics about obesity, including the prevalence, some of the causes, how to screen for it. But really, the focus of the talk today is going to be about therapy for obesity. We'll touch on lifestyle, but really medication therapy, which some of you may not be familiar with those medications. So I want to give you a more thorough understanding of them. So now what is obesity specifically? We know that obesity, it's a chronic condition characterized by an excess of body fat. And that excess body fat can then increase the risk for adverse metabolic, biomechanical, or psychosocial health consequences. Right now, in the US, 71% of adults have a body mass index or BMI in the range of overweight. Of that 71%, 42% have a BMI in the range of obesity, that body mass index, which we'll talk about shortly. There are so many causes for somebody being overweight or having obesity, and it really is a complex interplay, and that could include genetic factors, medical conditions somebody has, environmental conditions, medications they're on, as well as some behavioral factors. We know that because obesity is so complex, the causes, ongoing management is required in order to try and lose and especially maintain weight loss long term. And this is just a slide that I really enjoy looking at, and it reminds me of why I love this area, because you can see again that there are many factors contributing to obesity. And I always think about my job as a obesity medicine specialist as being somebody who's kind of a medical detective. And I'm looking to see which factors apply to which patients because there are different combinations in every single person. But again, it can be really difficult to figure out which of these factors are contributing. And that's kind of my role as an obesity medicine specialist. So I'm actually going to review some basic um, neurology for you in terms of the physiology of appetite and body weight regulation. And this is not going to be foreign to you if you have acromegaly. You're familiar with this area of the brain. So we're going to start looking at the brain. And we have the brain here. And if we go into this area here, you see the hypothalamus. And just below that is the pituitary, where we see most of these tumors, which are causing acromegaly, secreting excess growth hormone. They're originating in the pituitary. But the area above it, the hypothalamus, that's the area of our brain that controls our appetite as well as energy expenditure. So looking more closely at the hypothalamus, what I want you to focus on, and this is just, again, for your reference to let you know how complex the circuitry is here. So you could see these, there are two prominent sets of nerves. One is the POMC neurons or pro-opiomelanocortin neurons. And these neurons ultimately, when they're stimulated, they actually lead to a decrease in food intake and increased energy expenditure. The opposite side of the circuitry are the neuropeptide Y agouti-related protein neurons. When these are stimulated, they actually increase appetite. So you eat more and it decreases energy expenditure and you would gain weight. And really, what I want you to get from this figure is there are a lot of other organs in our body which can impact these nerves in different ways. So you have insulin, which comes from the pancreas, right? We think about insulin controlling blood sugar. That actually stimulates those POMC neurons, decreases appetite, and leads to weight loss. Leptin, which is a hormone that gets secreted from fat tissues, again, stimulates those neurons to lead to weight loss. Other hormones like peptide YY or GLP-1, which I'm sure you're familiar with now, that's glucagon-like peptide 1, which is in some of these medication therapies nowadays. but that's also a hormone that comes from your intestines, and it actually inhibits the other side of that circuit, those neuropeptide Y nerves, and it leads to, by inhibiting them, it tamps down the appetite. And we know actually GLP-1 levels in patients who are overweight, who have obesity, their GLP-1 levels, which help decrease appetite, they're lower in patients who have obesity. Lastly, the hormone I want to point to is ghrelin. This is a hormone, the only hormone that stimulates these neuropeptide Y nerves, and it leads to an increase in appetite. And ghrelin is secreted from our stomach. So when we think about, in addition to, again, that's our general nerves, neural circuitry, we think about some of the other things I mentioned that can be contributing to weight gain. But let's look at specifically in patients who have acromegaly, what are some of the possible additional mechanisms that might be leading to weight gain? Well, we know that number one, if somebody has excessive fatigue, can lead to decreased activity or hormonal changes, these could lead to weight gain, right? And some of the factors in patients with acromegaly are if you have another condition that is a result of the acromegaly, like obstructive sleep apnea, that could lead to excessive fatigue. Something like joint pain, right? If you have a lot of achy joints and arthritis, it's going to be difficult to keep up the same level of activity. But we also know that if you have the tumor and it's affecting some of those other cells in the pituitary, it could lead to low levels of testosterone, estrogen, as well as thyroid hormone. Additionally, treatment then for acromegaly can also have an impact on weight. We know that if somebody's treated and the acromegaly is controlled, there will be a decrease in those IGF-1 levels. And that actually does lead to changes in body composition, including a decrease in lean body mass and an increase in the percent of body fat. Also, it's possible that the tumor or the therapy for the tumor could actually lead to a patient needing to have either thyroid hormone replacement or testosterone or estrogen replacement. If these levels are not finely tuned for each patient and appropriate, that also could lead to excess weight. And lastly, one other specific challenge is something called hypothalamic obesity. And I just showed you that area of the hypothalamus. And I showed you it's just above the pituitary. So it's possible that if somebody has a tumor that's so large and going outside of the pituitary, it could bump into that area in the hypothalamus. So if it bumps into it and it's affecting those nerves that control appetite and energy expenditure, that could increase somebody's appetite significantly, leading to obesity. Also, if somebody has surgery, a transsphenoidal surgery, right, or radiation therapy to the pituitary, well, the hypothalamus is in that same area. So it could also be injured. And that, again, could lead to obesity through that mechanism. And what you notice in those cases is somebody will have treatment and then have a very rapid increase in both their appetite as well as their weight, like immediately after surgery. So suddenly coming home from surgery and within days noticing that you're just eating all day, you're hungry all the time, can't feel full. That's a symptom of hypothalamic obesity. Now, this is just a slide just to remind, I always like to remind everybody why it matters and we pay attention to obesity. It's because there are many medical conditions that can result from having excess body fat. And what you'll notice is even more so, several of these are also increased in patients who have acromegaly, such as pulmonary disease, obstructive sleep apnea, right? Coronary heart disease risk factors like diabetes and osteoarthritis. So it's even more important to control obesity. Now, these are just some of the things that I talk to my patients about. And if you're seeing a provider for weight, these are the types of questions they should be asking you. They should be getting a very detailed history in terms of how long you've been dealing with being overweight, what your highest weight was, why you're trying to lose weight. Is it just to decrease your medications or improve your mobility? Also, you want to think about What caused the weight gain? I mentioned, did you have it happen right after having surgery to treat acromegaly? Or was it something like a change in your job situation or where you lived? Were there times of rapid weight gain or medication starting and suddenly you gained weight after starting a new medication? Also, we want to know about what you've tried in the past to lose weight, whether that's lifestyle changes or over-the-counter medications, and did they work for some period? Also, thinking about your current level of dietary intake and activity. Additionally, of course, a medical history, a thorough medical history, surgical history, family history, and then, of course, a physical exam, as well as lab tests, because we want to make sure that other hormones are at normal in their normal ranges, like your thyroid levels. And this is just a slide to mention to you that there are many medications that treat common medical conditions like depression or high blood pressure or type 2 diabetes that actually cause weight gain. And the goal of somebody like myself is to review somebody's medication list and see if they're on a medication that's causing weight gain and see if we can shift them to one of the medications that actually can help with weight loss or is at least weight neutral. Now, I mentioned the body mass index previously, the BMI. And what is the BMI? It's a measure of simply your weight in kilograms divided by your height in meters squared. And again, this is used as a screening test. So screening tests are used for populations, right? We don't use it specifically to diagnose an individual, but it can be good in terms of populations, but it still has advantages and limitations. So the advantage of using a BMI is that if you want to screen every single patient coming into a clinic to find out what is their risk for having obesity, well, these are measurements that you can get quickly. They're not expensive. And overall, as somebody's body mass index increases, so does their percent total body fat. But it's not infallible, and there are limitations. We know it tells us basically somebody has a higher amount of weight, right? And we don't know if that higher amount of weight is due to higher levels of muscle, which actually in patients who have active acromegaly, right, you know that there's increased muscle mass. We don't know if it's due to excess or heavier bone density in a patient. It also has some other drawbacks, like it ignores ethnic variability. And we know that in patients who have Asian ancestry, they actually develop some of these cardiovascular risk factors we worry about at much lower body mass index levels. So it's not perfect, but what we try to do is use it as a screening tool to see if somebody's at risk, and then add to that additional information. The additional information we add is a waist circumference. So you can see that as you're going across the screen from left to right, the waist circumference is increasing, but also that's a surrogate measure for the amount of visceral fat increasing. And that's that fat deep in the abdominal cavity next to the organs. And that's the type of fat that's most concerning in terms of increasing the risk for heart disease, diabetes, etc. So when we evaluate a patient, we start by we do check a BMI just to kind of get a sense of what their weight class is, and then you check a waist circumference as well. And a waist circumference is elevated if it's over 40 inches in men, over 35 inches in women. And what we know is an increased waist circumference increases the risk for having those metabolic diseases like type 2 diabetes, hypertension, and cardiovascular disease here. So even at the same weight level, also having an increased BMI, an increased waist circumference means there's higher risk for these disorders. And we know, again, I need not mention to you that in patients who have acromegaly, there are higher risk for these metabolic disorders as well. So here you can see the algorithm, kind of the treatment guidelines for treating patients who have overweight and obesity. And it always starts with high intensive comprehensive lifestyle interventions. And that could be for anybody who has a body mass index, a BMI, of 25 kilograms per meter squared or above. And it starts out, again, it's supposed to be intense. So at least 14 visits in 6 months. And that's with a variety of healthcare professionals trained in this area. So that could be a physician, an obesity medicine specialist like myself. It could be a dietitian. It could be a behavioral therapist. It could be an exercise physiologist. There are a lot of people in this space, but it should be an intensive amount of treatment and visits. And the goal is 5 to 10% weight loss in 6 months. If somebody's not able to meet that, then they would move on to pharmacotherapy, medical devices possibly, and then surgery at these different BMI levels. But keep in mind, even if somebody moves on to medication therapy or even surgery, the high intensity lifestyle intervention continues. It does not go away. It's not an either or, it's intensive lifestyle intervention plus. Okay, so we're going to talk about lifestyle interventions, but I'm going to be brief in this area. You're going to have these slides to refer to, but what I want to stress is a few things. Number one, again, these are the cornerstones for all weight loss therapies. There are three different components: dietary, activity, as well as behavior. But the most important takeaway from this is it needs to be individualized for the specific patient you're speaking to and working with. So this is why I'm not going to spend a ton of time talking about these options, because it really just depends on that specific person. So in order to create a dietary plan for weight management, if you want to lose weight, you need a caloric deficit, a decrease in calories. And what study after study has shown is that it's whether or not somebody's able to adhere or stick to that type of dietary style and not the specific style that determines weight loss or not. So again, because it needs to be individualized, you want to base it on the patient, their preferences, and what's available to them. So that could include a prior dietary style that they followed for a while and did well with. It could be something related to treat another medical condition, like the DASH diet that can actually treat a dietary style that can actually treat high blood pressure. Mediterranean diet, we know, can be helpful with cholesterol levels and help decrease cardiovascular disease, mortality, and the low glycemic index style, which is basically focusing on getting whole grain carbohydrates. That could be useful in patients who have prediabetes or diabetes, or even in patients who have insulin resistance, which is prevalent in patients with acromegaly. Calorie counting is another simple option that patients might want to use. And again, you have to just think about what is most attractive to a specific person to follow. These are other options like meal replacements. They're convenient. They can be very convenient and not expensive compared with the cost of a full meal. Some people like using meal delivery services where you get a meal kit. Others, simple things like if somebody does consume liquid calories from like juice, soda, or alcohol, eliminating those can be an easy way to decrease calories. Or another simple method is to use something like the healthy eating plate, where you literally just have half of your plate. You could see here on the right of this diagram, half of the plate is whole grains and healthy proteins, lean proteins. The other half is fruits and vegetables. So it's a simple way, regardless of what types of foods are being consumed, to help decrease calories. In addition, I always highly recommend that people work with dietitians. Okay, so now if we look at lifestyle, physical activity, and again, I'm not going to spend a ton of time on this. You'll have the slides because it needs to be individualized. The physical activity guidelines, which hopefully are going to be updated soon, but these are from 2018, they basically want people to move more and say that you should get 150 to 300 minutes per week of moderate intensity activity, or half of that amount if it's vigorous. Also, if you do more than that, you would get increased benefits. And it's also recommended to do strength training 2 days a week. And these are just slides showing examples of what's moderate intensity, what's vigorous intensity, just to give examples, to be able to give examples to somebody and see what is most attractive to them. But what I find I spend a lot of time doing is actually helping people put in small bouts of physical activity into their day. So whether that's starting their lunch break with a 10-minute walk or taking a few breaks throughout the day at work to get up and do either chair stands or wall presses. And behavioral, again, these are just depending on the patient, it has to be individualized, but it could be anything from dealing with stress management, not having mindful eating and not eating while you're watching TV, because you're likely to, if you're watching a program, you're going to eat a larger portion. Also, behavioral tips like using smaller bowls and plates, and even stuff as basic as arranging the refrigerator where you keep fruits and veggies at eye level instead of, I always say, instead of having them in the crisper at the bottom where fruits and veggies go to die, right? That's all important. Also, self-monitoring. It can help us with our habits, to be aware of triggers, and it can help show your progress. And you could either do that with weighing, using food or activity journals. Activity trackers can be useful for people who don't get in. If you go and play pickleball for 1 hour, 3 times a week, then we know how much activity you're getting in. But if you're getting in little bits throughout the day, it could be very useful to have an activity tracker to kind of add uh, all of those activities up. And in terms of setting a step goal, this just gives a reminder to set it 500 to 1,000 steps above what that person's currently doing, their lowest days. And if somebody came to me with these were the numbers they had, I would go with a goal of 4,000 since they've got days down in the 3,000s. I would not start this person with the what you always hear 10,000 steps a day. You start where the person is. In terms of monitoring progress, of course, this could be through following either their weight, waist circumference, how to clothes fit, cardiovascular risk markers like a hemoglobin A1C, cholesterol, monitoring mobility. Is it improving? Can you walk longer distances? And monitoring levels of joint pain as well. Is it improving? Do you need to use pain medications like ibuprofen less often? Now we're going to move on into pharmacotherapy and talk about why is it so hard to lose and especially maintain a weight loss? Well, number one, our environment, with large portion sizes, it promotes overconsumption, and also technology discourages physical activity. We know that when we eat certain foods like fatty foods, sugary foods, it actually stimulates certain reward nerves in our brain that make us want to do it again. But also importantly, once we lose weight, our bodies are still tuned to actually help protect us from starvation. Our bodies think we're dying when we lose a lot of weight. So it's set up some protective mechanisms. For example, once you lose 10% of your weight, you're burning 15% less calories. Your body slows your metabolism, so you burn less calories throughout the day. Also, your muscles are more effective to try and burn less calories throughout the day. So during that same 3-mile run, you're going to burn 20% less calories. Also, some of these hormones I mentioned before, ghrelin, the one that makes you hungry, it goes up after you lose weight. You're hungrier during the day. And these other hormones like leptin and peptide YY, which actually suppress your appetite, once you lose weight, leptin levels actually decrease. So again, they lead to you being hungrier. So this would lead us in somebody who's not able to meet that weight loss goal or keep it off, we would move to the next step of pharmacotherapy. So here you can see the meds that are currently FDA approved for pharmacotherapy medications for weight. And one group is, I'll start with noradrenergic agents. These are FDA approved for short-term use, 3 months, because they were FDA approved back in the 1950s when we didn't know that weight was a chronic condition. But now they're often used for longer periods off label. And basically, they increase your metabolic rate as well as increasing dopamine levels to decrease appetite. You can see that on average, about 4.4% greater weight loss than somebody taking a placebo medication at 6 months. And because it increases your metabolic rate, it can increase your blood pressure. So somebody who's already got uncontrolled hypertension, uncontrolled blood pressure, you wouldn't use it in them. Or somebody with heart disease or an arrhythmia, or somebody with anxiety. And here you can see most commonly side effects are dry mouth and insomnia. Those are the most common ones if you take it particularly late in the day. And here you can see the most common names for these meds, phentermine resin, or diethylpropion. And these are typically dosed once a day. You could do a lower dose 3 times a day, but it's a pill that you're taking usually once a day. The next one I'm going to talk about is orlistat. It's not used very often, um, but because of the side effects, which we'll talk about in a second, but it is still available. And the way orlistat works is when you eat a meal and it contains fat, some of that fat has to be broken down by these enzymes. So picture these yellow balls are enzymes that are breaking down these fats in your food, and they're going to make it small enough to get absorbed into your intestines. Well, orlistat, that medication will bind to the enzyme. The enzyme then cannot break down the fat. So if the fat can't be absorbed, it's going to go out into your stool, which is where the side effects come from. But in terms of weight loss, average weight loss, mean weight loss of 5% at 1 year. In terms of side effects, as I mentioned, it's going to be related to the fat going out in your stool. So a greasy stool and bloating. Um, Patients need to do a multivitamin if they're taking it and need to separate it from medications like Synthroid as well. And it's again a capsule. There's a over-the-counter low dose or prescription dose. You take it 3 times a day with meals. Now let's get into some of the other medications that a lot of them are combo meds like phentermine topiramate. We talked about phentermine already, but topiramate is a medication that's FDA approved to be used on its own for people who have either seizure disorders or migraine headaches and need to take a regular medication. It's able to decrease appetite. We don't quite know the mechanism, but putting these two together, phentermine and topiramate, is able to cause significant weight loss. So we know that with phentermine topiramate, you start with all of these meds at a very low dose and titrate up. So you start at this low dose capsule once a day for 14 days, then go to the regular dose. Monitor for 12 weeks, and then assess to see if the medication is working, in which case you continue it. If it's not, you can either increase the dose to the higher dose or stop. In terms of how effective, the average weight loss is 8.6% at 1 year on the higher dose. And most common side effects are the ones from phentermine, but the new ones from being with adding the topiramate are constipation. Some people can get numbness, tingling in their hands and feet. And there can be some cognitive effects if you're on the high dose. Also of note, for women of childbearing age, if they were to become pregnant on this, there's increased risk for that fetus developing a cleft palate. So moving on to the next one, it's a combination med. Bupropion, you may be familiar with. It's FDA approved to be used on its own under the name Wellbutrin as an antidepressant, and also under the name Zyban for people to stop smoking. And naltrexone is FDA approved to be used on its own for patients who have alcohol abuse disorder or opioid abuse disorder. But putting them together, I'll show you how they can cause significant weight loss. So bupropion actually stimulates, here we come back to those POMC neurons that I showed you in the hypothalamus. Bupropion is able to stimulate those neurons and decrease appetite, increase energy expenditure, and lead to weight loss. But what we know is those nerves, just like most of the endocrine system, they come back and they inhibit themselves after they've released some of that hormone. They do that by a mu opioid, an opioid receptor. So giving naltrexone blocks that receptor so it does not inhibit itself, and it continues to go on and secrete more of that hormone and lead to weight loss. In terms of most common side effects, nausea, headaches, and constipation. Contraindications are seen here, people who have seizures, history of bulimia, and it's a pill. You can see it, the highest dose, the regular dose ends up being 2 pills twice a day. And that can be difficult in terms of patients remembering to take it. As far as weight loss, on average, 8% weight loss at 1 year. Now we're in the last bulk of medications, the GLP-1 based receptor agonist. And all of these meds that I'm mentioning next, they all work by, right? GLP is, I showed you, it's a hormone we already have in our body. And it gets released when we eat food. And what it does is it goes to the hypothalamus, leads to a decreased appetite, increases our sense of satiety, but also in our digestive tract, it slows down the movement of food from our stomach and our intestines. So food stays in your stomach longer before it moves out, it's going to be a longer period of time before you're hungry again. So it's able to help us with weight loss. Here we see liraglutide. This is a once-a-day injection. It's FDA approved under the name Victoza for type 2 diabetes, doses up to 1.8 milligrams. And at a 3 milligram dose, the higher dose is for weight loss under the name Saxenda. Average weight loss, 8% at 1 year. I'm going to mention these common side effects and contraindications here, and it's exactly the same for all of the last few meds that I'm going to go through. So most commonly, they're gastrointestinal side effects. I told you how it can slow down the movement of food through your digestive tract. So nausea, vomiting is possible. It's not so common, but it's possible. Diarrhea, constipation, and acid reflux. Rarely some adverse effects, pancreatitis, and also I'll throw in here cholecystitis or gallbladder disease can occur as well and is a little more common than pancreatitis. Contraindications, severe kidney disease. If somebody personally or their family has a history of medullary thyroid cancer, which is a rare type of thyroid cancer, or they have multiple endocrine neoplasia 2 syndrome, which is a rare syndrome that people may have, but they also have an increased risk for that medullary thyroid cancer. This is a once-a-day injection. You start at a very low dose, make sure the patient tolerates it, and move up to whatever the highest dose the patient needs in order to be effective. Okay, semaglutide, another GLP-1 receptor agonist, right? It's FDA approved at a lower dose, 2 milligrams, for patients who have type 2 diabetes under the name Ozempic. It's FDA approved under the name Wegovy at 2.4 milligrams for weight loss. On average, patients lose 14.5% of their weight at 1 year. We also know that in patients who have cardiovascular disease already and are overweight, but no diabetes, that this medication was also able to help them decrease future cardiovascular events like stroke, heart attack. So it's FDA approved for that as well. The side effects I already mentioned are the same as for liraglutide and contraindications. It's a once-a-week injection, and you start at a low dose and titrate slowly as the patient is tolerating it and to whatever dose they need to be effective at weight loss. Tirzepatide, this is the last medication I'm going to talk about. Tirzepatide, its combination, it stimulates those GLP-1 receptors and GIP. And GIP is another glucose-dependent insulinotropic polypeptide. And it's another one of those hormones that's secreted after you eat food. And it stimulates those neurons in the hypothalamus. So Zepbound, it's FDA approved for weight management, but it's also FDA approved within the past few months for patients who have OSA or obstructive sleep apnea and obesity. It's also FDA approved under the name Mounjaro for patients who have type 2 diabetes. And the doses are the same for each of these. In terms of the ability to cause weight loss, at 1 year, 20% is the average weight loss. And we know that some patients have significantly more, some patients have less. The side effects exactly the same as the previous ones. And again, it's a once-a-week injectable. And some of the questions that often I get about medication therapy is, how long do I need to take this? Can I stop this once I get to my goal weight? And the answer is shown in this figure here from one of the studies, the STEP 4 trial, where they had patients on semaglutide or Wegovy, and all of them, you can see them losing weight. Once they get to 20 weeks, they put half of them on placebo. So there's no medication in those vials. And the other ones, they kept on semaglutide. The ones that stayed on the medication continued to lose weight and do well. The ones they did not give medication, you can see they're regaining the weight. And it makes sense because we know that obesity is a chronic condition. And we know that if you're taking a medication that helps decrease your appetite, helps you feel more full and lose weight, if you remove that medication from your body, it's no longer going to have those effects. So we would expect you to regain the weight. And the point of that is these medications should be used long-term to treat this chronic condition. And just to mention, tailoring Some of these lifestyle plans for people who are on these obesity medications, I'll just mention, coming back to the lifestyle, the nutrition recommendations I said, they need to be tailored for the individual to treat whatever additional medical conditions they might have. But also, we can use the lifestyle changes to help treat some of the side effects from the medication. So if somebody's having diarrhea as a result of one of those GLP-1 receptor agonists, we can use soluble fiber, and that's the fiber you get in things like apples to help treat diarrhea, or soluble or insoluble fiber, that those greens or roughage, those can help treat constipation. So we can also tailor nutrition guidelines to help with medication therapy as well. You always want to encourage fluid intake because some of the medications that decrease appetite can also decrease somebody's thirst mechanism. Additionally, as somebody's losing weight, right, any type of weight loss can lead to the loss of muscle mass. So you want to be aware of somebody's protein goals and the amount that they're taking in. And it's a higher amount you could see here during the weight loss phase. So 1 to 1.2 grams per kilogram of protein per day. If they're weight maintenance, a little less. And then also physical activity. All of these are important. Aerobic resistance, especially to help maintain that muscle mass. Mind body, just for de-stressing, as well as balance training. And lastly, for patients, additional considerations with acromegaly. If somebody's on pituitary hormone replacement, and that could be thyroid hormone or other steroids, they should be monitored the levels and adjusted as needed with weight loss. You will need to adjust your levothyroxine dose if you have significant weight loss. And also in terms of glucose management, we know that these GLP-1 based medications and others, once you have weight loss, they're going to impact insulin resistance as well as glucose levels. So medications for type 2 diabetes do need to be adjusted. And lastly, I already mentioned there's a large team of professionals that take care of patients and are able to help patients be most successful with weight loss. And this is just summary, just to, remind you, there are many contributors to weight, being overweight and obesity, that you really do want to get a full and thorough assessment by somebody who's well-versed in managing patients and their weight. And you want to work on creating an individualized plan just for you, because that's the best way to have something that you'll be able to sustain lifelong. Um, in addition, you want to make sure that you have a provider that you feel comfortable with, right? Also, remember, consider medication if you can't meet your goal with lifestyle changes alone. And again, you would be adding on medication. It's conjunction with lifestyle, not instead of. I'll just mention, please be persistent and get a referral to a weight specialist if your primary care provider can't help you. And this probably is something I don't need to say to you patients who have acromegaly, because I know I've actually done studies looking at the average time it takes to get a diagnosis. And it has patients going to multiple providers over the years, sometimes decades, before you're able to get somebody to put the picture together. So I again advise you to be persistent. Ask for a referral to a specialist. You could go to ablm.org, find a provider. Also for a dietitian, eatright.org, right? And also, again, it's important to focus on the reasons for trying to lose weight, right? To improve those related conditions. And remember, even 5 to 10% weight loss can help decrease cardiovascular risk factors like blood pressure, cholesterol, blood sugar, as well as help improving mobility, even if you have arthritis, as well as quality of life. And I'll end there. And I once again want to thank you so much for having me here to talk to you about weight management. Thank you so much.